Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This podcast provides observations and commentary on the JCO article, The Prevalence of Off-Label Use and Spending in 2010 among patent-protected chemotherapies in a population-based cohort of medical oncologists by Rena Conti et al. My name is Dawn Hirschman, and I am an Associate Professor of Medicine and Epidemiology at Columbia University Medical Center in New York City. My oncologic specialty is medical oncology, as well as health services research. The overall mortality rates from cancer have improved significantly since the war on cancer began decades ago. While a great deal of this can be attributed to improvements in prevention and early detection, major strides have occurred in treatment as well, and these improvements have accelerated in recent years with an explosion of new drugs to treat many different types and stages of cancer. However, as with the rest of medical care, these advances have been accompanied by increased medical costs. Cancer-related medical costs have accelerated at a rate beyond those of other medical treatments, and this increase has been driven by a dramatic rise in both the cost of therapy and the extent of care. Physicians directly or indirectly can control or influence the majority of cancer care costs, including the use and choice of drugs, the types of supportive care, and the frequency of imaging tests. In 2012, the American Society of Clinical Oncology's Cost of Cancer Care Task Force, in an effort to reduce the financial burden of oncologic care, published 5 practices that are thought to be commonly used despite absence of evidence supporting their clinical value. One recommendation was not to use chemotherapy in a setting where there is no strong evidence supporting the clinical value. In other words, to stop using chemotherapy drugs off-label. While this makes intuitive sense, there is surprisingly little data available on the extent of off-label oncology drug use. Studies are limited due to a paucity of databases that capture pharmacy information, cancer stage, and the line of cancer therapy. In this issue of Journal of Clinical Oncology, Conti and colleagues use a novel database to examine the prevalence and costs associated with off-label oncology drug use. The investigators use data from a platform called IntelliDose. This is an electronic chemotherapy ordering software that can also be used for billing purposes and captures information such as cancer diagnosis, date of diagnosis, age, and gender on each patient. Every month, the information is updated, including cancer stage and line of therapy. The data are de-identified and stored centrally for administrative and research purposes. In this study, the data were analyzed from 122 medical practices. About 19,000 patients were included for all chemotherapy given in the year 2010. The authors were specifically interested in the most expensive drugs, so they evaluated drugs that had been FDA approved between the years 2004 and 2009 and were still on patent in the year 2010. The final analysis evaluated the use of docetaxel, gemcitabine, rituximab, trastuzumab, bortezomib, bevacizumab, cetuximab, pemetrexate, azacitidine, and albumin-bound paclitaxel. The authors classified the on-label uses for each of the drugs. Discrepancies were resolved by consensus amongst the authors. The authors then reclassified the group that was off-label as supported by guidelines from the National Comprehensive Cancer Network, or NCCN. On-label prescribing was defined as the number of annual administrations of on-label use divided by the total number of administrations. Annual U.S. sales for each drug were obtained, and the authors reported the spending associated with both on- and off-label use of each drug. Overall, the authors report that off-label use amounted to 30% of total chemotherapy use. Off-label use ranged from a low of 1% for trastuzumab to a high of 68% for gemcitabine. The authors evaluated the 30% off-label use and found that 14% of it was associated with an NCCN indication, and 10% was associated with an FDA-approved cancer site, but the wrong line of therapy. The authors determined that the national sales of the drugs were $12 billion in the year 2010. Based on the proportions they observed, off-label sales accounted for $4.5 billion. $2.5 billion of that was for off-label use not consistent with NCCN recommendations. The largest contributor to off-label use was bevacizumab. There are a few important points to make about these findings. While a large amount of money is spent on off-label use, the majority of its use is for NCCN-directed or compendia use, or it is use of a drug in an approved cancer but the wrong line of therapy. The reality is that the majority of use, 94% in fact, has some support in the literature. Is it realistic to think that all drugs can be tested in all cancers and all lines? Likely not. There are significant costs and human resources associated with those studies as well. And in some circumstances, it may not even be possible to test the effectiveness of every drug. It is reassuring to note that only a small amount of use was without any rationale. It only amounted to 6% of use, or $700 million in 2010 in the United States. Given that there is an unknown benefit to these treatments, and it is unlikely that every question will be answered with clinical trials, one may hope that in the future we will be able to better evaluate the efficacy of off-label use with observational data sets. While the use of off-label chemotherapy is limited, several studies have evaluated off-label use of supportive care drugs. For example, in a SEER Medicare study of erythropoietin use by Wright and colleagues reported in the JCO in 2011, ESA use was high and increased from 55% of patients undergoing chemotherapy also receiving ESAs to approximately 80% of patients receiving ESAs between the years 1996 and 2005. This was true even in the non-metastatic setting, where its use has been also associated with increased mortality. Whenever we evaluate the results from observational data, it is critical to understand the strengths and limitations of the data set used. First, we have to ask, was there selection bias? In this paper, the data comes from private practices and non-academic outpatient cancer care facilities that use the IntelliDose system. Because this system is used for quality improvement, there may be a selection for practices that are conscientious about giving quality care or using appropriate guidelines to direct care. The results may therefore not be generalizable, which would ultimately underestimate off-label use and underestimate the cost assumptions. In addition, the system is used for billing. It is possible that there are warnings about issues with reimbursement built into the system which would prohibit drug use without an appropriate billing code. As the authors point out, this would bias the results also to underreporting of off-label use. Finally, the drugs in the study were limited to those still on patent. However, off-label use may be far more prevalent in settings where the drug has been used for longer periods of time. Despite these limitations, given the paucity of data on off-label use of cancer therapy and the important cost implications associated with off-label use, This study provides critical information and emphasizes the need to better understand the patterns of use and costs, and ultimately ways to implement policy change to better regulate the use of these expensive medications. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.